right, good morning, everyone, or afternoon, depending on where we are at. Thank you so much for joining me today. I'm very excited to be speaking about a topic that's very near and dear to me today, which is individuals with disabilities and providing eye care to them. As an introduction, my name is Jen Martin. I'm an optometrist located in Boston, Massachusetts, and a faculty member at the New England College of Optometry. There are no disclosures for this presentation, and I'll be largely pulling from my clinical experience, which is at Perkins School for the Blind Low Vision Clinic, where we see mostly pediatric patients that have visual and multiple impairments. So when I was kind of putting this presentation together, I wanted to think about barriers, not only the ones that the patients face when getting healthcare, but ones that providers face as well in being able to provide that healthcare. I want to start from the patient's point of view, where they report difficulties regarding communications, attitudes being treated by healthcare providers, as well as difficulties with financial and transportational barriers, and finally, just the scarcity of service in the area that they can access it in. From the provider side, there are some similar concerns regarding communication with the patients, as well as lack of training and resources to provide care to this population. Other barriers, including physical space, as well as the healthcare system as a whole, can also provide barriers to being able to provide the care that we want to provide. And as we kind of start thinking out, I'd love to hear from you all some of the barriers to care that you most identify with, be that the communication, lack of training, lack of resources, physical barriers, or just barriers within the healthcare system in general. All right, looks like a good even spread across the board, with lack of training being one of the top ones. Hopefully after today, we can have a better idea of how to better communicate with these patients, as well as be able to find resources and be able to interact with them in a way that's comfortable for everyone involved. Oftentimes I'm asked, why work with this population? And we know that there's several different conditions that can be associated with ocular manifestations. For instance, the autism spectrum can of course have refractive error and strabismus or eye turns, but we can also see functional deficits such as oculomotor difficulties, visual perceptual deficits, as well as difficulties regarding visual attention. For the genetic condition trisomy 21, or also known as Down syndrome, we still see significant refractive errors, as well as keratoconus, giving significant astigmatism correction needed. We also see some structural changes, such as a higher incidence of blepharitis and dry eye, as well as early onset cataracts and brush-filled spots, which are an accumulation of iris connective tissue that can be seen on the iris, pictured here at the bottom. And then, of course, we still see strabismus, as well as accommodative dysfunction being common within this population. Cerebral palsy is a group of disorders affecting the development of movement and posture that can cause a lot of limitations as it comes to activities. It's often attributed to disturbances within the developing fetal or infant brain. Ocular manifestations, again, can include refractive errors, as well as structural changes such as optic atrophy. Strabismus, gaze palsy, and nystagmus are also highly correlated with individuals with cerebral palsy, as well as the brain-based visual impairment called cerebral visual impairment, or CVI. Of these three, especially within Down syndrome, we often see a lag of accommodation or under-focusing at near. Within Down syndrome, we see that there's a decoupling between that accommodation and convergence in the near triad. While they are able to converge, that accommodation lags behind and doesn't kick in as much as it should. There's still a lot more research to kind of be done within this area to determine if it's more of a central processing difficulty or related to acuity or something else. There are, of course, a number of other inherited syndromes and genetic disorders that have ocular manifestations. We see a significant amount of hyperopia in patients who have Fragile X syndrome, which is often seen in patients with autism. And of course, there's also strabismus, as we see in autism as well. Prader-Willi syndrome, another multi-system genetic condition. We can see nystagmus, strabismus, and a more higher instance of myopia. Beyond specific conditions, you can also have multisensory impairments, such as those who are deafblind. About 10% of children with visual impairments also have hearing impairments, with the majority being related to Usher syndrome. And of course, the ocular disease within Usher syndrome is retinitis pigmentosa. Oftentimes, these patients will need a more tactile approach in exploring their world, as well as in communicating with them. Finally, we also see several behaviors that individuals with disabilities may have that can affect their eyes, ranging from things like eye rubbing or other injury around the eyes, as well as light gazing. So now we kind of have an idea of some of the ocular manifestations that we can be looking for in some of these patients. We want to think about the behaviors that they may have and the potential limitations due to their impairments. In that vein, it's important for us as examiners to be able to adapt our approach in gathering the exam information to better match where the patient is. It really makes a more comfortable exam, not only for the patient, but for the provider as well. As the provider, this really starts with setting yourself up for success. You'll want to make sure that your outfit lets you move around, as you might not be just sitting in your exam chair, but moving around the room throughout the examination as well. A lot of times you'll want to be sure that you have long hair tied back, we're not wearing ties or dangling jewelry, as it can be a chance that things can be grabbed and yanked and pulled towards you, which we don't want. Oftentimes we really have to think outside the box and come up with different approaches. This means that we'll have to be sure to keep a number of different tools within our toolbox, so that way we can use and adapt them as needed based on the patient that presents. I often find that reflection on the examination really sets me up for future success. Interactions that went well, of course, are always great to keep in mind in order to use again in the future, especially those failures that you have, and considering why it didn't go well and how you can change your approach in the future. When I was first starting off working with patients who were no light perception, I would just start the exam being like, do you see the light on? Do you see the light off? And I had a rather upset teenager who was telling me that I've never seen light before. Why are you asking me this? And now whenever I approach things testing with lights, I instead have a conversation with them and just chat about how they're doing, while occasionally asking about the presence of lights. That way it's not completely focused on their visual impairment. As several of our patients may have visual impairments, I just wanted to touch briefly on some best practices, which includes identifying yourself whenever you enter the room. I often have all the interns that I work with go around and introduce themselves to the patient as well. You'll want to let them know when you're leaving the room, so that way they know that you have gone. It's really important that you continue to speak directly to the patient and allow for them to have time to respond. Narrating what you're doing is very helpful to orient them, and you want to be sure to use specific directional language in order for them to better have an idea of where things are related around them. Finally, using language such as see this or look at that is typical, and I would encourage you to continue using it, as it's often used in typical conversation. Communication approaches may need to be changed during these examinations. You'll want to allow for the patient to have some time to process what you have said, as well as time to respond to the question that you asked. This can vary between seconds to minutes, and sometimes finding out that latency interval is important in order to engage the patient. When you want to establish rapport with the patient as well as their team, I often joke around with my patients throughout, be sure to give high fives or elbow bumps. And often you'll want to rely on the caregivers that are coming with the patient, as they know that individual best. I'll often ask approaches such as, hey, will they do well with lights? Should we use eye drops? What would be the best approach to make them comfortable and to make everyone as a part of the examination? Being able to do this will allow you to better engage with the patient, which is our goal as the examiners. We want to really be able to adapt the examination so that way the patient can take part in the task. This is important, as we don't want to put the blame on the patient for not being able to take part in the task that is not accessible to them, and instead calling them uncooperative. Instead, we should find a way as examiners to engage the patient with the task, or make a note that we were unable to. As we get into the exam, before things kind of start, it's very helpful to have some records to give an idea of your patient profile. This can include other records from other eye care providers, ophthalmologists, oculists, opticians, etc., as well as from medical providers and educational or vocational reports. Knowing educational goals can be helpful to assess the visual aspect of things, especially for those that are still within the educational system, such as knowing their reading requirements, the distance that their tasks are often at, and what their future plans are after they leave the educational system. As there's so many different conditions out there, it's really impossible to know about every single one of them. Having these reports, though, can give you an idea of diagnoses that the patients have. And often I refer to the National Organization for Rare Disorders, or rarediseases.org. That provides an overview of what the condition is, as well as provides specific signs and symptoms that can be found in different symptoms. From there, I can see that if there are any ocular manifestations that I need to know about. And then from there, I know what to look for in the examination. Once the patient arrives, you can then go over with them and their team any ocular concerns that they may have or changes in their functional vision that have been observed. Discussing the environment that the patient is often in can be helpful in case of recommendations or modifications that need to be made, such as placement to reduce the impact of glare for your photosensitive patients. Discussion on mobility, as well as device use, can be helpful to see how the functional vision is affecting their everyday life. So, as we're kind of getting started, I want to pose a scenario for you all. So we're getting started with the examination. Your patient's rather upset, and we want to think what approaches can be used to help calm them down as we start the examination. Could this be playing music and shows that they are familiar with, starting the examination with games rather than specific tests, conducting the examination in free space rather than in the exam chair, or all of these are potential approaches? Wonderful. Yes, all of these are absolutely approaches and are all very great ways to engage the patient. For those that are very upset or uncertain before entering the exam room, I'll often ask their family that has come with them if they have any favorite shows or songs they like to listen to. Some patients will be like, let's put on SpongeBob or a favorite cartoon like Cocomelon, or other patients will have little Taylor Swift singing sessions, depending on what they find to be comforting. Allowing the patient to really explore the room can help them get used to the space, rather than just jumping right into the task and overwhelming them with not only a new testing area, but new tasks that might be more in their space than they want to be. Use of social stories can be used prior to coming to the examination, which shows photos of the different steps and objects that are used in the exam, so it's not new for the patient when they arrive. Other clinics I've been at have had images on the wall so the patient can follow along at each point of the examination, kind of like a schedule. At Perkins, during COVID, when we were full PPE, the mask, the hair bonnets, the gloves, everything, we would often send the patient's family photos of us without all of that on, as to try and remind tell the patients that we are human and not just some aliens in PPE. A lot of the examination is going to be reliant on some of the objective measurements and observations that you get during the examination. This can really start before the examination even begins in the exam room. Oftentimes, as I go out and greet my patients, I'll see, if they seem interested or a little bit more timid. Is the patient able to walk, or are they using a cane? How is their posture, their gait? Are they bumping into things? And as they enter that room, are they visually curious about the space, or do they kind of hang out in a corner and still not sure about everything that's going on? Of course, observations will continue throughout the examination, and this can include things like head turns, tilts, any gaze preferences, as these can give ideas for things such as null points for patients with nystagmus. And then, of course, use of other systems that might not just be visual or in conjunction with the visual system. So as we start to gain visual measurements, often I'll prioritize doing both eyes first to get an idea of the functional vision use. This is also helpful if I think that the patient may fatigue easily. Testing can be done with alternative materials ranging from your typical letters or number symbols, as well as different shapes, grading cards, or even real objects. Oftentimes, I'll often implement matching responses in order to help guide the patient a little bit better. If I am going in for monocular testing, oftentimes I may use a sticky eye patch, so that way the patient doesn't have to hold it, or use tape occlusion on the glasses, such as we have pictured here, or even just use of the patient's palm. It's important to make sure that anything that is covering the eye isn't pressing on the eye itself, as that can affect the acuity once we go and check the other eye. We often use Patti Pics or Leia symbols, both of which use the familiar shapes of circle, square, heart, and apple, but with just some slight variations in their setup. This can give us resolution acuity, which tells us the ability to resolve and identify that object. These can be done in a crowded line or a crowded card, as well as giving single presentation on the screen or with the playing cards. You can employ matching, like I mentioned earlier, which is great as you can straight up provide the image right in front of them for those who may not be able to verbally say the shape that they're seeing. You can also further simplify the matching in a two forced choice paradigm, making the patient have to choose simply between two images to determine which one matches the symbol that is shown. We of course have grading card acuity, which is our detection acuity, which can overestimate Snellen, as the patient merely has to determine if an object is there or not, rather than having to fully identify it. Pictured here, we have teller cards, which of course uses preferential looking with the idea that the patient will look to the side of the card that the grading is on, rather than the side that has nothing. It has different set distances, as well as norms for the first 24 months of life. When you use these cards, you really want to just assess which side the patient looks at. Sometimes if I'm not sure how the patient fixates, I'll start with some of the bigger cards and just show the very gross bars. From there, I can get an idea if the patient takes a while to fixate, is a quick fixator, then looks away, or if they need a moment to assess both sides before determining which side their choice is on. You'll want to make sure that your fingers are on the edge of the card and not leaning over into the card like it is on the right of this image, as that might draw the patient's attention and give you a false indication of where to look at the stripes. You'll also want to be sure that the examiner doesn't know the side that the cards are on, as that can bias the response that they believe they see as far as the eye movements. It's also important to test each side a couple of times in different directions before checking to see where the stripes are. Leia paddles, such as pictured here, are also an opportunity to use. However, again, you as the provider would likely know which one has the stripes and which one does not. However, you can still do things such as determining what ways the grading is going, as well as the directions up and down or side to side. Other approaches for those with poor acuity include using room lights or LED lights for distance and near light perception. Light perception is merely the ability to tell if the light is on or off, while light projection indicates that the patient can tell the direction that the light is coming from. It is important to make sure that the device that you're using doesn't emit heat, as I've had patients who were no light perception correctly tell me when the light was presented or not presented to them, because they were able to feel the heat of the light on their cheek when the transilluminator was shining on them. Functional acuities are also an option. As we know, visual acuity is simply the test distance over the object size. I've had patients who were not interested in doing teller and would simply look away and were very much driven solely by the toy that they came in with. And at that point, we decided to use the toy and place it at different distances without the patient looking and determine and see if the patient was still able to find it. Then took those measurements to see how far away in the exam room they were able to still find their preferred toy as the visual acuity. Contrast, or the ability to detect more dim and dim images, is not often tested in a typical examination, but can provide a lot of functional information. It's very helpful as far as safety and navigation, as well as a lot of reading materials often have a lot lower contrast, such as newspapers. Poor lighting only complicates that problem. Contrast sensitivity tests, of course, include the Pelly-Robson for those that are able to do letters, pictured here to the right. Berkeley disc here in the middle is another approach where the patient merely has to mark the squares that have the different circles in them. And then Heidi uses preferential looking, as you see where the patient looks to see if they are looking to a more faint image of the smiling girl. Drs. Mayer and Cran recently developed the double happy test, which also uses preferential looking. As you can see here, the smiley face stays the same size, but will get dimmer and dimmer as we go through the card deck. Just like teller acuities, you simply present the card and see where the patient's gaze is looking. Here pictured, we have Dr. Mayer, one of the creators of the double happy, showing the child the smiley face, and he's correctly looking to the side that it is on. As a reminder, contrast sensitivity norms are listed here with typically 1.65 log contrast being within norms, but of course the values are a little bit lower as for children who are still developing. And I will be sure to see about getting these slides to you all so that way you can see some of these resources and other norms and data I have here. Visual field, of course, is the ability to detect objects within our seeing space. There's many functional implications for visual field loss. Besides mobility and orientation, it can impact things like visual search, as well as socialization with others, as parts of facial expressions, body language, and pieces of sign can be obscured. Reading is also impacted, especially when the blind spot's near fixation. When we think about it functionally, for my patients, I often think about where they should perhaps be sitting in a classroom or within group work, or where material should be presented to them in space to allow for maximum accessibility. I'll typically test this again with both eyes open and in free space in order to allow for less claustrophobia and make it a little bit more motivating. Sometimes I'll have other family members kind of jump in and help me out to see about having the child sit in their lap or what might make a good fixation target, such as a toy or a video. You just want to be sure that whatever you're using as your fixation target isn't too distracting as to not be aware of any targets that you present onto the sides. Approaches, of course, can include our typical finger counting or kinetic finger fields. Oftentimes, I'll use a Leo wand or a flickering light wand as pictured at the bottom here. And I'll have one of my interns present the lights from both sides from behind the patient, while I take a look from the front of the patient to see when they avert their gaze to see where the light's coming from. There will still be some patients that you can engage for more traditional visual field testing, such as on the Goldmann perimeter. It's really great for plotting both central and peripheral fields and really allows for frequent breaks and modifications of the approach in order to be a little bit more individualized for your patients, unlike some of our more automatic perimeters. There's several norms that are included as far as age, but of course, since we can modify it, we can even test patients who are even younger. I recently had a 23-month-old where we suspected side vision loss. And while this isn't necessarily a reliable field, we did have the patient sitting in the mother's lap, looking at a spinning light target in the middle. And every time she was looking to the center, we would flash a light to the side and make a marking when she did avert her gaze, giving us grossly full side vision. Other perimetry tests exist that use gaze aversion, often using a video eye gaze target, as well as peripheral lights to help quantify pediatric patients' visual fields. As we move into refraction, retinoscopy is going to be your best friend. Oftentimes, I'm relying on the cycloplegic retinoscopy in order to determine the glasses prescription. Near testing can also take place to determine the refractive error, such as the Mohindra technique, which is done in a dark room at 50 centimeters and subtracting 1.25 diopters from your final retinoscopy to get the final RX. You can also use the monocular estimation method, or MEM, to assess for the accuracy of the accommodative system, as we know that some of these patients may have a more impacted accommodative system than others. While the ideal target is, of course, one that you can accommodate to, we want to make sure that it's one that is interesting for the patient as well. So once I had a patient who had about a +2.5 lag of accommodation using our traditional MEM symbol card. However, his mother was like, I don't think he's really looking at your symbols. How about you use one of his favorite toys instead? And while it might not have been the most appropriate target, he certainly behaviorally began to engage more with the target and toy once we used it. And we saw that his lag of accommodation disappeared and was within norms. So it's important to make sure that while doing the test appropriately might be important, you want to make sure that is, again, meaningful for the patient, so the data that you're getting is accurate. Doing all of these tests within free space is going to be important, and this will be use of trial frames or loose lenses instead of using the lens or retinoscopy rack. Oftentimes, this really helps reduce that feeling of claustrophobia and makes the patient feel a little bit more relaxed. Finally, if I do find a change, depending on the patient's level of cognition, I might ask if they notice a subjective difference in the room or what they're watching on the television through the trial frame or with holding the lenses over. If the patient says, yeah, I think there is a little bit of an improvement, we can go back and test acuity to see if there is a measurable one and make our decision on the prescription from there. For motilities, it's important to have an interesting target. Most often I'm using spinning light toys, as pictured here. However, you'll want to check in with the caregivers to ensure that's not a trigger to the patient for seizures or other things. Other options, of course, can be following a phone as it moves, or a tablet playing a video. And sometimes I'll even pull out a mirror and test the patient that way. From the mirror, I'm also able to get some functional vision information, such as patient's attention, fixation, as well as interest level in looking at humans, and even the ability to recognize themselves. Color vision can be assessed a number of ways. Formally, I often use the Wagner Color Vision Made Easy, which is pictured here in the center, which is a pseudo-isomochrotic color vision test that is employable for patients up to an acuity of 2200. What's really nice about this one is that every page has a circle as one of the shapes. And in the office, we use the wooden circle toy pictured here and give it to the patient and have them match it to the big circle. This allows us to be able to assess color vision formally. Of course, if those approaches don't work, you can always assess color awareness, such as with the colored chips and matching them to be the same color. For my patients that may have lower acuities, I'll pull out a light box and use some translucent chips pictured here in order to determine what level of color vision or awareness they have. Pictured here at the bottom, we have the PV16, which is the low vision version of a D15. And again, we can do color identification through completing a fish puzzle that we have in the office to see if they match the body to the head with the right color, as well as using the caterpillar test and asking about color naming during completion of that task. Alignment can be done in free space without getting up too close to the patient. If cover test isn't an option, we can look at the pupil reflex through the Hirschberg method. Here we see that the left eye's pupil reflex is displaced inward, suggesting that the left eye is out, an exotropia. Krimsky can then be used to assess the magnitude of the deviation by measuring with prism until the two reflexes are aligned to get that magnitude of the turn. The caterpillar test, as we mentioned on the page previous, can also be used to assess alignment while they string the chips onto the string, as well as using Bruckner to see the pupil reflex and if there's any inequality in that red reflex. Depth perception can be tested a number of ways. I enjoy using the PASS test pictured here, which is a forced choice test giving with one blank card and one card with a smiley face that can only be seen through the use of the polarized glasses, making it a global stereo test. The child will then kind of decide between the two cards, which you can see either through gaze or the patient pointing and verbalizing, which can be great to assess the level of depth perception present. I'll also have local tests, such as the random dot 3 or stereo fly, which has more monocular cues. And then for those patients that polarized glasses wear isn't an option, we have the lane test, which is going to be the only one that doesn't use glasses. Testing of saccades and pursuits can be helpful, as oculomotor and binocular vision problems can arise within this patient population. In NECO, testing of saccades and pursuits can easily be modified. For saccade testing, I'll often ask the patient, or instead I won't even ask the patient, I'll have two light toys and I'll see how they shift their gaze as I turn one light on and off to the other. Oftentimes, I'll assess pursuits while doing motilities as to not tire out the patient and reduce the number of tests that we're doing all at once. For those that are able, the developmental eye movement test, or DEM, pictured here, as well as the King Devitt, can provide more information on saccadic dysfunction. As we move into the health assessment, it'll be important to maintain as much free space as possible. This means using handheld, portable equipment, which will be important as it's less intimidating and can also be used elsewhere in the room and not just in the exam chair. Sometimes I'll have my patients sitting at a small kids table we have in our office, or laying on a couch or a mat that we have in the room as well, and then we'll test them wherever they're at in a way that's comfortable for them. For externals, we'll often use a handheld slit lamp, or more often, a high-powered magnifier with white and black lights. This allows us to move around the room a little bit more and is a lot less terrifying to the patients than having to sit in a more claustrophobic slit lamp. Intraocular pressures is often best done with eye care or tonopin or other free space device. I'll always talk my patients through what's going on and what's going to happen, including any lights or sounds or sensations they may experience. Oftentimes I'll call my eye care the tickle machine from how it brushes against the eyelashes, which can startle some patients if they're not looking forward to it. Of course, palpation is an option as well, and oftentimes I'll play boop, boop, boop on their foreheads before going for their eyes as to acclimate them to it a little bit better. Much of the dilated health exam will be through binocular indirect ophthalmoscopy. When dilating, oftentimes I recommend using a combination drop, which might be the best approach to get as much dilation in there. For the older patients, I'll kind of discuss with them the options of using a numbing drop beforehand and let them decide if they would rather more drops that with less sensation or less drops with more sensation. Other times, I'll instill the drops by having them close their eyes and simply instill the drops into the inner caruncle and have them blink it in. For patients with motor difficulties, oftentimes I'll recommend the eye drop squeezer. We have an image of one such here, which can be helpful in reducing the amount of pressure needed in order to get the drops out of the bottle. After instilling the eye drops, I always occlude the punctas. As we've seen, many of our patients can have a number of other diagnoses, and we'll want to ensure that the systemic absorption is as minimal as possible. Oftentimes, I may do BIO through using a video or a light toy to kind of direct the gaze, or other times I'll just have the patient watch the TV and I'll move around them to get the views that I need. If I know that it's going to be a limited examination, definitely I will prioritize the posterior pole in order to get the most important view in and give myself the most information. What I also find to be really important in all of this examination is documentation. I don't always get out to the far periphery, and sometimes my view of the optic nerve is simply it's sailing by in my view for half a second, and that's the best view I'm able to get. It's important to note that if your views were fleeting or mark, any limitations that you might have had in the examination, as well as anything that was helpful, such as any specific shows or toys that the patient really enjoyed that helped them increase their engagement. General modifications overall just include, really meeting the patient where they're at. For those that are a little bit more tactile defensive, you'll want to consider starting with tasks that are outside of their personal space, things like acuity or motility, or just observing alignment, rather than getting right in personal early on. Giving frequent breaks is very important. And while that time may be used to play or listen to music by the patient, observations can still be made by the examiner to determine how their vision is being used, as well as in conjunction with their other senses. Modeling tests to patients beforehand can be helpful in getting them prepared for what's going to happen. This can be done on toys, caregivers, on the examiner, on their hands, etc. There's been many a times I've given eye drops to a doll before I've given eye drops to a child, and it can be very helpful as they'll understand what's kind of coming for them. One of the biggest assets I think we have in our exam room is a television all the way across the room. I've mentioned several times that we often ask the patients seeing that they're interested in watching, and then we'll put on SpongeBob or what have you on the TV. And all of a sudden I have a great target to do cover test or have a great distance retinoscopy target, and really gets the patient to engage with something that isn't looking right at my light when I don't need them to be. I'll also use the distance target to kind of get a subjective idea of any changes in prescription that we found by asking if they feel like their favorite show looks any better through the new prescription. For those with multisensory impairments, it will of course remain important to continue to collaborate with the caregiver on approaches to communication. Oftentimes I'll continue to narrate what I'm doing with the patient, as well as ask for interpretation as needed. A lot of these patients may need more acclimation for touch, as they don't have visual or auditory sensation that it will be coming for them. This can be starting with kind of hand holding and rubbing the patient's hand to let them know you're there. And then slowly I get them used to having them feel my hand against my face, and that can kind of help them get used to me kind of working around them when I'm doing VIO or looking at the health of their eye. Tactile approaches within demonstrations, as well as explanations, can be helpful for this patient. And again, I really recommend speaking to the caregivers that are with the patient. As we're kind of wrapping up the examination, we'll want to make sure that we see what the initial concerns were from the patient and their team and address them. Families are really going to be wanting information on the functional vision and how it can help their patient at the home, at school, or elsewhere that they're at in their day-to-day lives. You'll want to make connections on how we change the testing approaches and the environment and how that can be adaptive to modifications that can be made elsewhere. For instance, patients who were licensed into the exam room and needed everything conducted in the dark, we'll want to make sure that we recommend they sit away from banks of lights and that their backs are facing to windows or other glare sources. For patients with visual field loss, we'll provide descriptions of the best places to present materials. And for those who have light perception acuity or low contrast, we'll make connections and recommendations to using high contrast materials, or even use of high contrast clothing, makeup, or name tags to help with patients identifying people around them. You'll definitely want to make sure that you're clear about the follow-up to your clinic, as well as making sure that they're looping in with the other care that they have elsewhere. Oftentimes, you might be collaborating with other providers, not only vision care, but those on the educational or rehabilitation team, such as teachers for students with visual impairments, orientation and mobility specialists, occupational therapists, physical therapists, what have you. It's really important that all of these team members kind of talk with each other and are in communication, as well as sharing the outcomes of their assessments with each other. Sometimes we may discover changes to visual function or implications that can be made to the other therapies that they're having, and we'll want to make sure that the way things are presented to the patient is consistent across the different therapies, so they're able to maximally engage and take part in something that's accessible to them. Finally, the reports generated from the examination outlining the findings, as well as implications for visual function, should be made. You'll want to make sure that your recommendations are in plain language, as it may be shared with those who are not as savvy with eye care world or work as closely with eye care professionals. All right, as we're winding down, I have a true-false question for you all. True or false? There's no need to provide glasses, a prescription, if you do not think that the patient would wear it. So the majority is going with false. And for me, that is the correct answer. So as far as glasses, if we find a need for them, specific refractive errors, concern for amblyopia, a near ad, we should provide the prescription, even if we're not sure if the patient will use it. Not only can it provide clarity in acuity and vision, but it can be protective to the eyes as well. Of course, patients can be tactile defensive, and we'll consider things such as desensitization programs, which is taking steps in order to get patients to tolerate things a little bit better, such as glasses wear or use of eye drops or what have you. When I talk to those who do desense work with some of my patients, they talk about just getting some sunglasses, having the patient hold them, having them accept it touching them, slowly working on to having the sunglasses touch their face, wear of the sunglasses, and then transitioning to day-to-day glasses. Similar things with eye drops, such as practicing first on a toy, then on the patient's skin, then on their cheek or forehead, and then slowly getting to the eyes. Oftentimes, this can help the patient accept glasses wear a little bit more, which can continue to go on throughout their life. When getting glasses, it's going to be important that the patient's there so the frames fit and that they are of a style that they enjoy. You want to consider use of a strap to keep the glasses frames on a little bit better, as well as use of flexible and durable frames, especially for those who might be more likely to take them off and toss them or chew on them or just lose them. For those patients that are in need of devices, low vision or otherwise, if the patient's developmentally ready, it should be provided. And oftentimes you'll want to connect it to something that the patient's interested in and not necessarily something specific for school or their vocation. This could be using a monocular telescope to birdwatch or a dome magnifier to look at comic books or other things that are interesting for the patient. It'll be important that they have support at home and school to continue facilitating and improving their use of the device. These days, you have a lot of questions regarding optical versus electronic devices. For optical approaches, I'll often think about any motor difficulties that the patient might have. And that will determine if I'm going to give a standard handheld magnifier or if I'm going to use something that has a stand, like a stand magnifier. For our electronic approaches, there's often a lot more customization that you can have, such as changing the font size, the text, changing contrast options, screen brightness, so many things, as well as having access to speech to text. Many options, as well as currently a lot of the alternative and augmentative communication devices, or AACs, that a lot of our patients may use are now on iPads. So when my patients come in with any type of communication device, I'll kind of measure the images that they have, see how the spacing looks, the contrast of the icons that they're using. And if I have any findings in my examination that suggest that perhaps they can't see the size of the icons or the contrast isn't high enough, we can make those recommendations to their team members to explore a little bit more in order to make sure that the device remains accessible for them. So as we wrap up, I have a few different resources that helped me kind of put this together. Of course, the Special Olympics is an incredible organization that provides a lot of healthcare opportunities to individuals with disabilities. As a part of their program, they provide health screenings, not only for the eyes, but for several different systems. The Special Olympics finds that about 2 in 10 athletes in a Special Olympics team have never had an eye exam, and that 4 in 10 are in need for a new prescription for glasses. Oftentimes, the Special Olympics will link up and try to facilitate some of this in order to get access to healthcare and eye care for these team members. For those patients that are still within the educational system, I'll often direct them to Perkins' expanded core curriculum. It involves a number of life areas from compensatory skills, assistive technology, self-determination, and career in education, which allows for a more positive transition into the community once the patient graduates, as well as teaching them self-advocacy skills. The American Foundation for the Blind provides a lot of career guidance, research, and advocacy for individuals with disabilities. The World Institute on Disabilities has several resources on accessible design of healthcare systems, community inclusion, as well as career and financial planning. The Center for Disease Control also provides a great disability inclusion resource that is about overcoming barriers, similar to the ones that we discussed at the start of this lecture. For those with children, I often recommend the book here at the bottom, as it provides guidance for parents through the educational planning process at all points of the educational system. A few advocacy resources I recommend include Special Books by Special Kids, which has a social media presence as well as internet website that's really sharing stories of individuals with various conditions and disabilities in their day-to-day lives. Positive Exposure is an organization promoting inclusion in fashion photography. Shown here is their special in a 1998 issue of Time magazine, highlighting individuals with albinism. I really find these resources great, as you can hear in the words of potentially our patients, some of what they experience day to day and how we can better support them. Some of my final resources include the 10 Commandments of communicating with individuals with disabilities. Of course, the CyberSight website has a great series of videos on caring for patients with disabilities that goes into more depth on a lot of topics that we touched on here, such as refraction, eye care examination, surgery, and other considerations. CVI Scotland provides a great overview of cerebral visual impairment, which is the leading cause of pediatric visual impairment in developed countries, as well as providing several suggestions for modifications that can be made for these patients. And then finally, some of the texts I often refer to as I was making this lecture. So as we wrap on up here, I have a singular question and would just love to see how everyone is feeling now as far as comfort in giving care to individuals with disabilities. I'm glad to see we're feeling overall more positive after this. Well, thank you to everyone who came in this morning. I'm happy to take questions in the Q&A. Alrighty, so the first question I see here is any special consideration for cycloplegic drops in patients with disabilities. Oftentimes, I'll definitely consider those who have cardiac concerns or any of our other standard contraindications regarding cycloplegia in our patients. Of course, there's a lot of concern with patients who have Down syndrome or trisomy 21 and their ability to take cycloplegic drops. Typically in this instance, a lot of my patients are co-managed with other providers. And if they have previously in the past done a cycloplegic dilated examination without any adverse effects, I'll feel more comfortable also doing a cyclo examination. However, if I don't have any documentation there, or of course there's any contraindications, I'll continue use of tropicamide or other weaker use of drops. Another question is, how would you assess vision refraction in elderly patients with hearing disabilities? For these patients, oftentimes I'll again rely on a more tactile approach. Something that I found to be helpful, especially with refraction, is when doing 1 or 2 to tap on the patient's arm 1 or 2, and then do the change of course at the same time and kind of doing a refraction that way. Sometimes having yes or no answers or questions can be more helpful when working with patients with hearing impairments, as well as seeing if they have any other alternative communication devices and styles that they use. Another question is regarding giving the patient glasses when they were born with an ocular condition. It definitely kind of depends, though I feel like if the patient's able to tolerate it and that there's still preservable vision, wearing glasses will continue to protect the eye from any injury. There's some thoughts that should we treat amblyopia or other refractive concerns in patients who have optic nerve concerns like hypoplasia or optic atrophy. And to an extent, I think it is worth giving the glasses prescription, especially when they're within that critical period, in order to provide some of those connections to still be made. I think it's more important to, even if the acuity is never going to be a perfect 20/20, excuse me, if you will, I think it's important to provide the best possible view that one can get, and that will include continuing to do glasses care as the patient's developing visually. Another question regards EUAs, or examinations under anesthesia. A lot of these patients, I will, if it seems like eye drops aren't going to happen, if it seems like they're very tactile defensive, it's not going to happen. I'm not someone who enjoys pinning down children or my patients at all. And if I don't think that's going to happen, I will refer for an EUA. Definitely, there's some of my patients where that's just going to be a much better approach for them. I've gotten a couple of questions regarding mental illness and disability, and I think it definitely falls under a disability category, if you will. A lot of times these conditions or these diagnoses have significant impact to day-to-day life that don't allow them to necessarily partake as one typically would, and that in itself is a definition of disability. So definitely can impact different points of the day and different things. And say you have a patient that's particularly anxious, you might need to take a little bit of more time and a little bit more slower communication style and some of what we talked about here in order to make them feel more comfortable and help them engage a little bit better. I have a question here about age limits for optical and non-optical devices. And, for me, I don't think of an age limit per se, but rather where the individual is both developmentally, cognitively, and things like that. I've had very young children who were able to use a monocular pretty quickly and didn't have any difficulties, whereas I've had older children who couldn't figure out how to use a handheld magnifier. So really it's going to be a little bit in office of seeing how they use it, how comfortable are they and what they can achieve with it. And if I think that there's some possibilities there, I'll recommend that their team explores it a little bit more with them. However, I always think it's important to make it known that these devices are going to be tools to use and not just toys to play with. I see a question here about managing visual impairments among prisoners, as they're a vulnerable population. And I have had some experience working with this population as they have come into some of the clinics I have worked in. And it can definitely be very difficult, especially kind of coordinating with the institution that they're at and making sure that they make the follow-ups, which might not be always possible. So for these, patients that are having a little bit more vulnerability and might not be able to make as many return follow-ups, I take a little bit more time with these patients and kind of see multiple different problems that they may be having and try to address as much as possible kind of going in. So that way we can try to make sure that we're maximizing the time that we have together to address as much as we can for them. So I see a question here about how we can manage children between 3 and 5 to wear glasses. And this is definitely that age where my patients start throwing off their glasses and not wanting to wear them. As I mentioned, kind of use of a strap can be helpful to at least keep it on the head or at least keep it on the body if it does come off. A lot of times we'll want to make sure that it's comfortable for the patient. So I have had a number of people come in and they're like, oh, the child never wears the glasses, it's not great. And then I look at the glasses and it's completely smushed up against their face, pressing the eyelashes into the eye. And no one wants to wear anything like that. So something I always kind of do first is make sure that the fit is comfortable and that's not brushing up against the eyelashes or pinching the ears or anything like that. At that point, if we're still having difficulties, sometimes I recommend my parent to caregivers to put the glasses on and immediately provide a toy or something interesting for the patient to look at. So that way kind of directs their attention away from the glasses that they don't want to something that they do enjoy. Sometimes another thing that I have done or told parents to do is to kind of place the glasses on while the child's asleep. So they wake up with the glasses on and might not think about it as much. So those are some strategies that can kind of be used there. All righty, so I have a question here about discussing with patients of children with low vision. And a lot of times within my patient population, at least, there's a lot of, they already kind of have their diagnoses and have an idea that their child's visually impaired. So a lot of times we're not necessarily discussing, oh, your child is the B word, blind or visually impaired. But oftentimes, if that is the conversation we have, I always point to, this child is exactly the same child that walked in an hour ago. While they might have a new label, if we give a new diagnosis or something like that, I always kind of discuss how that can be empowering for the child, how we have answers to perhaps any difficulties that they may have, and that it will also allow them to have access to different resources and support strategies to make sure that they can thrive and be the best that they can be within their life. So I really appreciate everyone coming in today. This was a wonderful chance. So I want to thank CyberSight for having me today. And if there's any more questions, I have had my email here on the slide. So hope everyone has a wonderful rest of your day and take care.